Now, you mentioned about funding options. Of course, this is really hard. You're going to be asking people who often don't have much money to come back and see you again. So you need to work out what are your funding options in your particular situation. So depending on the age of the patient, in Canterbury we have up to 3 youth mental health consults a year funded. So this might be an ideal time to use those. If there's any questions about sexual health, you can call it a sexual health consult for that age group. If there are injuries, put an ACC claim in because that gives you a little bit of funding, $24 or whatever it is. Equally well funding for people who are got drug and alcohol problems or who are on certain antipsychotics. That allows you to explore their physical health issues with funding. We have SIA funding, disability allowance. You have to work out in your area what funding streams are available for you to use in this circumstance. And sometimes you have to bite the bullet and see them for free. You know, you just have to judge what will work for you. If you're an employee, that's often a bit harder. But as a practice or as a group, you need to have these options sorted out in advance so you know what you've got. And then down at the bottom, options within a practice, you might have a brief intervention counsellor or you might have a social worker from your PHO that enables you to refer people on within the practice. If they're not ready to go to an external agency, often that's a really good way of starting, or other PHO mental health options. We have a huge number of resources available to support us in our communities. Now, there's no point in me putting up what's in Christchurch here because you all come from different places. But that's why it's worthwhile having a look. If you've got health pathways, have they been localised? Talk to your family violence coordinator in the hospital and say, you know, can you contribute to make sure these are up to date for us? The assessment and management part doesn't need to be changed, but it's the referral options that you want up to date for you. Police and somebody from Refuge are coming this afternoon. Really important that for things like protection orders, the Family Court website has got a really good page all about protection orders, which are now free, and people can actually apply for them themselves. They can do it online, but I mean, it takes a bit of technical know-how. But so, for example, Women's Refuge spends a lot of time helping women apply for protection orders, and it's free and they can do it now. That's changed. It used to only be able to be done through lawyers. Okay, the other part of my talk was about, well, what about if somebody asks you to see a patient in respect of injury assessment? Now, I recognise that for some of you this might not happen, but in primary care it does happen, and it's going to happen more. Because I was saying about strangulation being a really significant issue in relationships like this, the law is going to change and strangulation is going to be measured in a legal way at a higher level than ordinary assault, male assaults, female. And so it's going to become incumbent upon the police to be able to prove that a strangulation might have taken place. So they're going to end up having to send more people to go and see doctors. So, going back to our patient at the beginning, we've got a 19-year-old patient. She says she was assaulted by her ex-partner yesterday and she was told to go and see the doctor to record her injuries, etc. Is it your job, any of the doctors in the room? Yeah, you know this. It actually, a lot of people think, oh no, they should go and see the police medical officer or somebody else, not me. But actually, the Health and Disability Commissioner wrote an article on this after a complaint was laid, and he said, no, actually, it is part of our role. We should be able to assess injuries, write them down and refer people on, make sure they're supported with Refuge or another agency in your area. So given that it is your job, and when I went to medical school, nobody ever taught me this, you actually have to understand the difference between treating somebody who's fallen over and sprained their ankle when you just say, oh, okay, you need to go and see the physio. You don't usually ask great details about exactly how did you sprain your ankle and what happened and which position were you playing in netball again and all that sort of thing. We don't usually do that in health because we don't have time. But in this situation, you actually need to think about it a little bit more and put a different hat on. So, you ask her a little bit about it. What happened? Tell me a bit about what happened. And she says that she was hit and punched and that she was choked. And you know that choking means strangulation. Non-fatal strangulation, but it's not attempted strangulation, it's strangulation, non-fatal strangulation. And you say, oh, I remember Claire told me something about that. So you look it up on Health Pathways. So on Health Pathways, there is a physical assault pathway as well, because I know that it's really hard for us when we haven't been trained in this to know where to begin. It's not actually difficult. It's about taking a history, just like you normally do. But also just asking things like, well, did it happen, were you wearing clothes at the time? Or were you in your nightie? Or were you naked? Because if you think about it, if somebody's hit and punched and they're wearing their winter jacket and jeans and boots, you might get different injuries to if she was in a nightie or nothing at all. So knowing about that's quite helpful. And knowing when it happened. So if she says yesterday, what time yesterday? Because if it was 4 o'clock in the morning, her injuries might look a bit different to if it was midnight. So the time as well as the date of when it happened is useful. Your time and date will be recorded on your computer system. And then, does she have any other things that might affect her skin when you're looking at it? So if somebody has chronic eczema, for example, it's important to note that because that can affect how your skin looks. And then, how are you feeling now? What hurts? What doesn't hurt? Because you need to make sure you address whatever it is that might be causing her distress, particularly at that time. And then if there was a strangulation, as she said there was, that's a really common form of family violence, but you need to ask a few more questions. Because if I said to you I was strangled, you wouldn't quite know okay, that's the neck, but what else do I need to know about it? So it's really useful to know a little bit more. Oh, I've covered these things. So all those things you're going to be looking at. And then you need to know, where were you? Were you standing up? Were you sitting down? And was the person in front of you going like that? Or was the person behind you going like that? And the reason you ask that is because if you think about it, if I'm going like that and strangling somebody's neck with my fingers, you might get bruises there because you put a lot of pressure in your fingers there. Whereas if I'm behind you with my arm, the pressure is dissipated. So you're less likely to get little bruises that way. So asking, where were you, where were they? And just noting that down. Did it happen once? Or was it something like on, off? Did you lose consciousness? Lots of people tell me sometimes when this happens, they wee themselves or poo themselves. Did that happen for you? So I've said lots of people tell me, so I'm used to hearing about this. It's nothing freaky. I'm just asking you some questions. So it normalises that question of intimate questions. Because believe me, if somebody's been strangled, they've wet themselves, they're not rushing to tell the police about that. Do you understand what I mean? So it's about giving them the permission to do that. And sometimes they will have tried to get whatever it is off their neck, and so they'll end up with sort of scratches on their neck that they've done themselves, trying to get whatever it was off. So then you're going to look at them and see, well, what kind of injuries have they got? And I know that nobody taught me how to describe injuries, but I think it's really important if you know what a bruise looks like, and call it a bruise. Don't get complicated, call it a bruise. And then there are a couple of other injuries that are useful to know about. One is an abrasion. An abrasion is a scratch or a graze. You can call it a scratch or a graze, that's fine. Then the third one is a laceration. Now, in health, we call lots of things lacerations. I review lots and lots of notes, particularly from ED and from hospital doctors, where something has started off being a laceration, it's become an incision, and then it's become a stab wound. And you think, well, that's, just with 3 people calling it different things. So sort of understanding what's what is helpful. And picture tells 1,000 words, so I've put pictures on here. So if you look at the top, you've got a bruise and then an abrasion. Now you can see that abrasion there. What do you think those are? Somebody's wrist. They're not cuts, no. They're abrasions, they're grazes, okay? So somebody has done this with the end of a compass or something. So, that doesn't matter, but knowing that that's an abrasion is quite helpful. Or if a child falls off a bike and they graze their knee, that's an abrasion, right? The next one is the laceration. Now that's somebody who's walked in, an elderly person who's walked into the open dishwasher door, here. And so what's happened is the dishwasher door has gone onto their fragile skin and it's split it open and it's bruised it and it's made a messy injury. That's a laceration. And I know that whatever caused that, it was something blunt that smashed into it and smashed the skin open. This one over here is an incision. Now that was a plumber, I think he was, and he was cutting some tape and he missed and cut himself with a scalpel thing or a sharp knife or something. And you look at that and that's lovely and neat and tidy, no bruising. That's been done by something sharp, that's been done by something blunt. And that's why it's really useful to understand the difference between those two. Rarely do you see stab wounds in primary care because they're usually gone to ED. Bite marks can look like that, so I wouldn't worry too much about those. But if you look at these pictures and you look at somebody with injuries and you think, which of those is it? And have a look. And you think, oh, it's that one. Okay? Now, you've got to write down what you see. It's medically correct. We have to record our interactions with patients. We have to do that. You know, what do they present with? What's your assessment? What are you going to do with them? Write it all down. What interaction did you have? It's an ethically right thing to do. The only thing I'd say to be aware of is to record what the patient says. So patient says she was assaulted by her ex-partner. Don't write patient was assaulted by her ex-partner unless you were there and saw it. Do you see, understand the difference between objective recording and subjective? The former will be really helpful. The latter, you're accidentally being a wee bit biased because you weren't there, you don't actually know if that's what happened. But you might think, oh Lord, I don't want to go to court, and if I write it all down, they might get me. Well, they'll get you if you don't, believe me. They'll get you and say, can you remember what happened? And you haven't written anything down. You think, ooh. If you write it down, more often than not, they won't get you there. They'll use your notes. Okay? So it's a really good thing. The other thing to think about is if somebody has injuries, take photographs and put them in the notes. Because that might mean you don't have to go to court, but it also might mean she doesn't. If there is a photo showing something, then often she doesn't have to go to court because there's some notes and a photo. So the way to do it, I'll show you. You don't have to write a story. You don't have to write a novel. You might think so after what I've just been telling you, but you don't. You need to use the non-judgmental language and observations, and if possible, just use quotes from the patient, put inverted commas around them. And remember about your computer codes for screening. So here is an example on health pathways of what somebody has recorded about the patient they saw. So the patient says, so she said, I wasn't there, I don't say it happened, she says she was assaulted by her ex-partner 28 hours ago. So I haven't put the time and date, but I've worked out it was about 28 hours ago. On questioning, she says she was hit with a wooden bat on the back of her lower legs, and she was punched on the right cheek or eye area, somewhere up there. She was strangled with one hand from in front. So I haven't written any more detail than that, just one hand from in front, that's enough. She didn't lose consciousness, no loss of consciousness. He released the grip after 40 to 50 seconds, and she said it was a bit sore to swallow for 12 hours or so overnight, but it's okay now. On examination, there's a blue-black bruise over the right infraorbital area and upper cheek. So it's not saying, you know, on the mandible, this 3 centimetres below this, it's just giving you a picture. So you're all picturing this woman now with a bruise on her cheek. You don't need any more detail than that. With there's a 1 centimetre. Now this person couldn't remember what that thing was I said, so they've written it. A 1 centimetre gaping break in the skin. So the skin's broken over a cheekbone and it's a bit gaping and a bit messy, with irregular edges and surrounding bruising. So what is that? A laceration. So by describing it like that, it enables somebody else to say, oh, that's a laceration. Instead of just calling everything a lac, just describe what you see and don't worry about the words. She's got a tender area on the left side of her neck with a 2 centimetre area of red tender bruising on the neck below the angle of the jaw. Blue-purple bruising over the mid-left calf. So no measurements or, they haven't measured it from the knee or anything, they've just given us a general idea. Linear edge to the bruise. That's quite interesting. There's a linear edge to it. So it's not a round one like that, it's got a linear edge. But gosh, she says she was hit with a bat. So that might be why. But they've described the bruise. They haven't interpreted it, they've just described it. Which is about 6 centimetres diameter oval. And there's a similar smaller bruise on the right calf. And then assessment. What's this doctor going to do about this? They're saying, well, actually the injuries, like that, she needed a bit of steri-strip to the laceration on the cheek, but no other specific treatment was required. So she hasn't required stitching up or anything like that. And the plan, she's got support from a friend, and she's meeting somebody from Women's Refuge tomorrow. The police have been in contact with her, and she's had photos taken by them earlier today, so this doctor didn't need to take any photos. But if I got those notes, that's brilliant. Absolutely brilliant. But it's not it's not a book. But it is enough to really inform things. So what happens is, if a doctor writes notes like this, then often what the police will do is they'll get the photos, they'll get these notes, they'll send them to me and say, can I write a report about it? So I would write an expert report based on those notes. That's why I get to see lots of doctors' notes and lots of ED notes and things, and I realise that They're very poor because people aren't taught this stuff. So that's why it's on Health Pathways. It won't happen often, but when it does, it's really nice for you to know that there is some help. And think, right, I've got to do this as best I can, this is what I need to do. And sometimes writing it on a piece of paper and then going back and kind of framing it up for your computer notes can be helpful. I often do that when I see patients. I write it on paper first. What about the perpetrators? Perpetrators are people. They didn't start life like that. Something's happened on the way. And I'm an optimist, and I always think people need to be given opportunities to try and understand what's happening. Now, as I was talking with somebody over morning tea, many people by the time they're adult have very ingrained behaviours. And if you think about your own work circumstances, if you've ever worked for somebody who's a bully, would you ever confront them? Would you ever challenge them on their behaviour? Are you good at that? I'm not. As health professionals, we're very easily manipulated. We're very sympathetic. We try to understand. We're not good at tackling perpetrators. Send them to the experts. Send them to the people who are good. There is a move in New Zealand in the police and justice sector to try and tackle this and say, look, we've been good at putting in services for the victim, but we also need to think about the perpetrator because they're going to go on and do it to someone else. So perpetrator services are being developed. They're not great everywhere, but they are being developed. And the reason is because we recognise that that's what we need to do. We need to try and hold people account for their behaviour and help them make changes. In particular, if you're seeing people in a general practice setting, relationship counselling is not a good idea because there's usually a power imbalance and you can imagine the manipulation that can go on. Personally, I don't do counselling anyway, but I'd be very careful in this sort of a situation of doing it. It's much better to send people to experts. There's a few really useful resources. The It's Not Okay website I find fabulous, particularly when you're talking with friends or family members, or even with victims and they're not sure because they've got some fabulous stories there and they can relate to stories. People can relate to stories of how other people have found things and what's been helpful for them. If you're dealing with elder abuse, they've got particular dynamics going on there and it's often children who are doing the abusing and that can be really complicated, but there's a lot of help on websites, the Super Seniors website. And if you search EARS, E-A-R-S, that comes up with age concern, but it also will come, you can find your area and see who offers that service in your area, which is the elder abuse services. On this website here, it's Melbourne University, and they've got some very good role plays of health service providers interviewing women and men about relationships and family violence, and it's just nice to see other ways of doing things. So I found that quite interesting. Now, there are lots of resources that are very helpful to have, and I think if you think about your workspaces, it's really good to have posters and things because that gives the message that this is an okay place to talk about things. That one might be a bit confronting, but this one might be better. So if you have posters like this around your workspace, it's giving subtle messages. If in the toilets you have the little cards or the it's not okay things, you just put them on a shelf in a toilet and people can help themselves. It just sets that whole scene for being asked about it when they go into a consultation room. So you can go to Community and Public Health, the Are You OK website, you can order off that. Ministry of Health has got some excellent resources too. It's just that one. Oops-a-daisy. Okay, so I'm going to be finished a little bit early, which allows you to ask questions and bring your own stories if you want to. But I think family violence is a really big health problem, and we need to recognise it as a health problem, not just a contributor. It's got to be that in the middle there, if somebody is experiencing family violence, that is affecting their health. And what we need to do in primary care is to recognise that and to try and intervene and offer support, but recognising that just like smoking, there's a cycle of change. You just have to keep giving the same message. Interventions can be effective for all three, the perpetrator, the victim and children. And it can be really hard to start routine inquiry, but just do it like I did. Say, this morning I'm going to ask one person, and then debrief with somebody in the practice. Oh, what happened and how your heart rate went, and actually it was okay. So debrief and group support is really good, and doing it in a group and in practice or in your work environment and deciding how you're going to do it, getting all the resources set up, getting your policies sorted. Every workplace should have an intimate partner violence policy and a vulnerable children or child protection policy in place, so there's a pathway. You know where you're going if this arises or that arises. And if we don't do anything, we're actually making the problem worse, because the victim thinks they're right. They are useless, hopeless, and it is their fault. And the perpetrator thinks it's okay to behave like that if we don't challenge things. And as a society, we need to be challenging things. We need to challenge the behaviour when there's a rugby match that goes the wrong way. People beat each other up. We need to say that's not okay, you can't do that. And we are changing as a society. It's Not Okay is doing a really great job of public awareness, but we all need to do our bit as well.